Okay, so let's get into all the different types of psychological disorders. And this is not going to be a comprehensive assessment of every possible psychological disorder, but we're going to highlight some of the key ones, and we're going to walk through then some of the biology behind that. So, how common are psychological disorders? And we're going to, as we get going, you'll see what's classified as a psychological disorder. But you're not going to need to memorize this, but I wanted to highlight the fact that across the world, psychological disorders are quite prevalent. In the U.S., 1 in 4 individuals, so it's one of the highest in the world, have some form of psychological disorder. That's 26%. That's quite a bit. Other countries like Canada and Mexico, France, they're not far behind. So it's quite a serious issue, and it's very, very prevalent globally speaking. So, what are we defining as a psychological disorder? This is a set of behavioral and or psychological symptoms that are atypical. So by that we mean that they're different than the cultural or societal norms that are around us. So atypical, like the name implies, is things that are not typical. And so this is where it gets a little bit gray, in that sometimes how do you define, normal? What is typical? And I don't have a perfect answer for you, other than based on specific disorders, we do have a fairly clear understanding of things that are different than the norm. So psychological disorder is a slightly dated term, and so now we use terms like mental illness or mental health. We also have the term of psychopathology. These are more current terms that are a little bit more culturally sensitive, and they're a little bit more indicative of what's actually happening. So in the past, psychological disorders were considered sort of their own thing, and now they've been more embraced as an actual medical disorder. And so it's something that you can treat. It's something that you can have some different options for. So things like pharmacotherapy or medicines that you can take, and you're also going to have support groups or therapy. So these are now treatable. I don't want to say preventable, but there's things that you can do to help prevent them. But you now have options. It's a disorder with some treatments. Now, what we're going to do is we're going to get into 2 different approaches to medicine and health. And one is a little bit more dated, and one of them is a little bit more current, and one's a little bit more specific, and one of it is a little bit more inclusive or holistic. So we'll start with the BPS model, or the biopsychosocial model. And what that one does, like the name implies, is looking at 3 different components or 3 different drivers behind our health. And first being probably the most obvious are biological factors or physiological factors. What is happening inside of your body? So how are you feeling? Psychological factors are what's going on in your mind. And then the third, which is more on the newer front, would be social factors. And we'll kind of break down each, and we'll get into that. Now, let's compare that to the biomedical model. So this is a little bit more dated, and this is kind of the traditional way in that we approached medicine and we approached health. And that is, you had your health, which was how you're feeling, and then we have other factors which are independent of your health. Things like your psychological factors and social factors. So your health is more directly associated to your biological drivers, and the other things are separate issues. It's not to say that they're not important, but in the past, if you were sick, that was usually attributed to something physiologically wrong with you. So, if you think of the times in the past when you were not feeling well, the mentality was, you're not feeling well, you have an illness, and I'm going to treat that illness with medicine, and that'll get you back to being healthy. As opposed to the biopsychosocial model is looking at it from a different vantage point, is saying, well, how can we be healthy? And being healthy is not simply being devoid of an obvious illness. So 2 different ways to approach it. So we say in the BPS model that a healthy state is not a steady state. So just because you're not visibly sick, that doesn't mean that you're healthy. It's something that you want to continue to achieve and try to improve and get better at. So you right now, sitting there watching this, how do you feel right now? If you don't have a cough, if you don't have a headache, if I asked you, are you healthy right now, would you say yes? And it's not that that's a wrong answer, but the better question is, I should be asking you is, how healthy are you right now? Are you at your peak healthiness? Have you achieved that magical state of perfection? And I'm sure for 99.9% of us, the answer would be no. You could always do better. Could you have gone to the gym a little bit more this week? Could you have eaten a little bit better? Are you eating a bowl of Cheerios right now? Or are you eating a bowl of Cheesies right now? There's things that we can do to always do better, right? So the BPS model thinks that and believes that that is a goal, as opposed to the biomedical model where you're trying to say, well, you're healthy because you're not sick. So we're going to look at a couple of comparative characteristics of each and see how they differ. So the biomedical model reduces everything down to simple things like you're sick because you had a bacteria or a virus, and I'm going to deal with that, and you're done. As opposed to the BPS model looks at both macro and micro level things, what's going down right at the lower levels and what's happening on a broader perspective. So it's trying to get a more holistic, we call, or more complete picture. With the biomedical model, a single causal factor, as opposed to the BPS, is looking at several different things: bio, psycho, and social. The biomedical model assumes something called mind-body dualism, and that is, it believes that your mind and your body are two separate things. And so one doesn't necessarily influence the other. And if you're sick, it's because there's something wrong with your body. And if you're having a psychological disorder, it's because there's something wrong with your mind. The BPS model believes that these things are so intertwined that they're inseparable, and one will directly influence the other. In the biomedical model, we emphasize illness over health, as opposed to the BPS model, which says emphasize both health and illness and looking at things like prevention and achieving a goal of trying to be healthy. So if you were to put all those factors together of the biological, the psycho, and the social, and you try and get some of the variables for each, the middle is where you would see you're actually achieving good health, good mental health, and good overall health. So biological would be things like your physical health, how you feel, what is your genetic predisposition. Psychological would be things like self-esteem, coping skills, social, who's around you, what's your peer network, how are you doing in school, where do you fall on the socioeconomic scale. All these things where they overlap and you're getting a full picture is what we're talking about here. Now, why do we want to study and examine psychological disorders? Well, it's kind of important because, one, you need to identify and better understand what are the symptoms associated with each. And then next figure out what is the prevalence or how common is this? Because as we'll see today, there is a whole slew of different psychological disorders. It's not so cut and dry. You have lots of overlap. You have a whole bunch of variety. And it is almost overwhelming to try and to assess somebody and try and establish what physical disorder they might have, because you need a good understanding of the symptoms associated with each. And then you need to figure out, well, how do I treat that once you've identified it? And then how common is this? So how do we do that? And how is this all documented? Well, we have the Bible, which is the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. And it's put out by the American Psychological Association. And they've had several renditions, and this has been around for years. And the most recent one that's out right now is the DSM-5, or the DSM-V. And what it does is it actually tries to categorize and outline all the different types of psychological or mental disorders, and it defines them. It'll talk about the pathogenesis. It'll talk about what are some of the characteristics that you see, treatment options, might even mention prevalence. And so it's a way to say, well, it's in the DSM, so this is, A, legitimate, and B, because it's documented, I have some better understanding of the variables and characteristics around it, and it might also have some treatment options. So the DSM is adapted to align with current evidence and practice, and what we're saying here is that they keep coming out with newer versions as we begin to understand more. So that being said, the DSM really hasn't changed a lot over the last few years. I think the gap between the most recent versions of the DSM-5 and the 4 was, I believe, almost 20 years. So I think it's 19 years. So in that 19 years, it's not like we've, rewritten the book. We've simply added a few things, rejigged the organization because of our understanding. But the idea is we have one place where somebody can go to and really try to figure out what it is that's ailing you. We also have something else called the International Statistical Classification of Diseases and Related Health Problems, called the ICD. A lot easier to say ICD than that whole name. And it's put out by the World Health Organization. And again, what we do here is we have different codes and a map of all the different disorders and how they're linked. And so as a psychologist or a physician, you can write down the ICD code for, say, for example, somebody suffering from generalized anxiety disorder. That would have an ICD code. You can see where it fits in the grand scheme of things. You could refer to the DSM-5 and look at some of the characteristics and symptoms to make sure that they align with your assessment of your patient or who's in front of you. So, what are all the categories of psychological disorders that you can have? Well, again, this is not meant to be an exhaustive list. I think we just want to highlight some of the more common ones. And for your MCAT, again, I don't think you need to know every single one, but you should be familiar with these. So things like anxiety disorders, and we'll go through each of these in more detail, but very quickly right now, anxiety disorders, dissociative disorders, mood disorders, eating disorders, personality disorders, sleep disorders, psychotic disorders, substance-related disorders. So you can see we're covering a whole range of things, being from obvious things like mood, depression, anxiety, to things that might be considered a little bit more fringe, like sleep or eating disorders. But the idea is there is a psychological driver behind these, and they're deviating from the typical societal norms. So let's start going through each now. Anxiety. So what is anxiety? So this is an emotional state. So it's a more emotionally driven of unpleasant physical and mental arousal. And so what happens with individuals with anxiety is that you have these intense, frequent, irrational, and uncontrollable episodes. And so their thoughts and behaviors get a little bit out of control. And when you speak to individuals who have anxiety, they say, my mind's racing a mile a minute and I really can't control where I'm going. And the thoughts don't necessarily make sense. They become slightly irrational. So, for example, somebody who's suffering from anxiety might say, I have an appointment at 10 o'clock, but it's 9:10 right now, and I haven't put on my pants yet, but my pants are still in the dryer. That reminds me I need to get a new lint remover for the dryer, and the stores are going to be closing in 20 minutes, and the car needs gas, and how am I going to make it to the store? So you can see it's snowballing out of control, and their thoughts are going frantic. It's not that they're not connected, but it's slightly irrational, as opposed to somebody who's maybe not suffering from anxiety might say, I have an appointment in 20 minutes. I should probably get a move on and get in the car and get going. End of story, full stop. So you can see how one is going quite frantic and one is a little bit more controlled. And that's the biggest descriptor that they say is I have a lack of control of my thoughts.
Let's have a view on the different types of anxiety disorders. First, there is separation anxiety disorder. The individual with this disorder is fearful or anxious about separation from attachment figures to a degree that it is developmentally inappropriate. There is persistent fear or anxiety about harm coming to attachment figures and events that could lead to loss of or separation from attachment figures and reluctance to go away from attachment figures, as well as nightmares and physical symptoms of distress. Although the symptoms often develop in childhood, they can be expressed throughout adulthood as well. Another type of anxiety disorders is selective mutism. This is characterized by a consistent failure to speak in social situations in which there is an expectation to speak, for example in school, even though the individual speaks in other situations. The failure to speak has significant consequences on achievement in academic or occupational settings or otherwise interferes with normal social communication. Next, we have specific phobia. Individuals with specific phobia are fearful or anxious about or avoidant of circumscribed objects or situations. A specific cognitive ideation is not featured in this disorder, as it is in other anxiety disorders. The fear, anxiety, or avoidance is almost always immediately induced by the phobic situation to the degree that it is persistent and out of proportion to the actual risk posed. There are various types of specific phobias, for example, with animals, natural environments, blood injection injuries, just to name a few. Then there is social anxiety disorder. In this case, the individual is fearful or anxious about or avoidant of social interactions and situations that involve the possibility of being scrutinized. These include social interactions such as meeting unfamiliar people, situations in which the individual may be observed eating or drinking, and situations in which the individual performs in front of others. The cognitive ideation is being negatively evaluated by others, by being embarrassed, humiliated, or rejected, or offending others. Next on the list is panic disorder. The individual with this form of anxiety disorder experiences recurrent unexpected panic attacks and is persistently concerned or worried about having more panic attacks or changes of his or her behavior in maladaptive ways because of the panic attacks. Examples could be the avoidance of exercise or of unfamiliar locations. Panic attacks are abrupt surges of intense fear or intense discomfort that reach a peak within minutes, accompanied by physical and/or cognitive symptoms. Panic attacks may be expected, such as in response to a typically feared object or situation, or unexpected, meaning that the panic attack occurs for no apparent reason. Now, let's talk about agoraphobia. Individuals with agoraphobia are fearful and anxious about two or more of the following situations: using public transportation, being in open spaces, being in enclosed places, standing in line, or being in a crowd, or being outside of the home alone in other situations. Then there is generalized anxiety disorder, or GAD. The key features of GAD are persistent and excessive anxiety and worry about various domains, including work and school performance, which the individual finds difficult to control. The individual experiences physical symptoms including restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating, or mind going blank, irritability, muscle tension, and sleep disturbance. And as a last type, there is substance medication-induced anxiety disorder. This disorder involves anxiety due to substance intoxication or withdrawal, or to a medication treatment.
Now we're going to get into somatoform disorders, and this is a psychological disorder characterized primarily by physical symptoms. And the reason why we're making this differentiation is this is quite common, is individuals coming in saying, I have this general pain in my legs and my back. And, the doctor might say, well, okay, you have this pain, and that's what you're describing to me. I'm going to try to treat that pain. So they might give you a treatment therapy that typically works for low back pain, but it's not resolving the situation for you. The reason is because the main driver behind why you're expressing that lower back pain is not actually physical. It's not that you've pulled a muscle or you have a certain virus that's causing an inflammation in your back. It's psychologically driven. And so a medicine is not going to treat your psychological disorders. You need a medicine that's specifically psychologically oriented, right? So this is why it's difficult for a lot of doctors to try and figure out and establish, is this truly a physical disorder, or are these really physical symptoms, or is this a psychological disorder that's being expressed as physical symptoms?
So a broad description of somatic symptom and related disorder could look like this. Everyone reacts on an emotional level when they have physical symptoms. However, people with a somatic symptom disorder have exceptionally intense thoughts, feelings, and behaviors in response to their symptoms. To distinguish a disorder from a normal reaction to feeling ill, the responses must be intense enough to cause significant distress to the person, and sometimes to others, and/or make it difficult for the person to function in daily life. So let's delve deeper into the SSRDs. The somatic symptom disorder replaces several previously used diagnoses, such as somatization disorder, hypochondriasis, pain disorder, undifferentiated somatoform disorder. All of these disorders involve somatization, the expression of mental factors as physical and somatic symptoms. There are several criteria to diagnose a somatic symptom disorder. First, one or more somatic symptoms that are distressing or result in significant disruption to daily life. Second, excessive thoughts, feelings, behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, excessive time and energy devoted to these symptoms or health concerns. And then, as a third point, although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent, typically more than 6 months. SSD now includes an aspect of understanding pain. This was previously captured by pain disorder. Now, when diagnosing SSD, you are asked to specify if there is predominant pain, previously pain disorder, for individuals whose somatic symptoms predominantly involve pain, and also ask if there is persistent pain characterized by severe symptoms, marked impairment, and long duration, so for more than 6 months. Then you want to determine the severity. This is gauged by specifying if only one of the symptoms specified in criterion B is fulfilled. Then you have a mild severity. If 2 or more of the symptoms specified in criterion B are fulfilled, you get a moderate severity. And if 2 or more of the symptoms specified in criterion B are fulfilled, plus there are multiple somatic complaints, or one very severe somatic symptom, you get a severe case. There are several types of SSDs you have to know. First, let's start with conversion disorder. It is a form of somatization in which mental factors are expressed as physical symptoms, thought to be caused by mental factors such as stress and conflict, which individuals convert into physical symptoms, tends to develop during late childhood to early adulthood. It may appear at any age and is more common among women. Symptoms include paralysis of an arm or leg or loss of sensation in a body part. Symptoms may resemble a seizure or involve problems with thinking, difficulty swallowing, or loss of one of the special senses such as vision or hearing. Symptoms usually begin after some distressing social or psychological event. Symptoms are not consciously produced, meaning people are not faking their symptoms. The next type is illness anxiety disorder. In this case, individuals are so worried that they are or might become ill that they become very distressed and have difficulty functioning. Doctors diagnose the disorder if people continue to worry about having or getting a serious disorder, after a thorough evaluation has ruled out serious disorders. Individuals may become overly anxious because they misinterpret insignificant physical symptoms or normal bodily functions, such as awareness of the heart's beating. This tends to be a chronic condition. In facetious disorder, individual pretends to have or producing physical or psychologic symptoms for no apparent external reason. Individuals imposed on self repeatedly fake having a disorder. If they have a disorder, they exaggerate or lie about symptoms, pretending that they are sicker and more impaired than they are. However, this disorder is more complex than simple dishonesty. It is a mental health problem that is associated with severe emotional difficulties and potential personality disorder. Lastly, there are psychological factors that affecting other medical conditions. The individual must have a diagnosed medical symptom or condition other than a mental disorder. Attitudes or behavior can negatively affect any disorder, such as diabetes mellitus, heart disease, or migraines, or symptoms such as pain. For example, severe stress can temporarily weaken the heart, or chronic work-related stress can increase the risk of high blood pressure. Impacts on the pre-existing medical condition can include denying the need for treatment, denying the significance or severity of symptoms, interfere with treatment.
Okay, now let's talk about schizophrenia. Schizophrenia is a mental disorder that's characterized by abnormal social behavior and failure to understand reality. So this is one of those disorders that is fairly I don't want to say that it's more important than others, but it's more, I would say, dramatic than the others because of when you're expressing schizophrenic symptoms, it's a removal from reality. So you don't know what's real and you don't know what's fake, and that can be very, for a non-schizophrenic individual to experience that and see that, it's kind of scary. So symptoms of this are classified into two bins. We can have positive symptoms and negative symptoms. Positive is where you're adding something to the equation, so you're seeing something that's not there, versus negative, which is a removal or a deficit of something. So we'll take a look at this in a little bit more detail here. So positive symptoms can include things like delusion. So now you're adding sort of mysterious things that you're seeing. Disordered thoughts and speech, hallucinations. These are all things that are considered positive symptoms. Now, positive symptoms respond quite well to medication and treatment, so that's a good thing, obviously, and it's a good thing because some of these things can be quite dramatic and can really impact your ability to function. So it's kind of hard to do your job when you're seeing, flying unicorns and you're seeing odd things, and also delusions where you have this disconnect between what's really actually happening and what you think is happening in your mind. So in this image that you're seeing here, you see a cat, but the cat has delusions of, we'll say, grandeur. It thinks that I am a cat, I am a wild cat, I'm a lion. When reality is it's actually just a good old cat, but in its mind, it believes that it is a powerful lion. It's Simba walking around in the jungle, okay? Now, the flip side are negative symptoms, and these are a little bit less responsive to medication and psychotherapy, pharmacotherapy, and things like removal of normal emotional responses. So you have a flat affect. So normally, me and you are having a discussion, and if I'm worked up about something, you'll know that I'm worked up because you can see that emotional expression of emotion attached to the conversation we're having. And sadness and all the different things that you would express, as opposed to an individual who has lack of affect or flat affect might be quite monotone. It might say things like, yeah, I may have killed a man yesterday and I also then won a $50 million lottery. And there's no emotion there and you don't know, are you being sarcastic or is this for real or do you know what you're saying? And then also the reduced quantity or fluency of speech. So they might not be saying a lot, maybe just a few key words. They might be mumbling a little bit more. It seems very forced in the way that they're speaking. And these all are then, again, classified as negative symptoms.
So, altogether, schizophrenia is characterized by loss of contact with reality. That's called psychosis. Patients may have hallucinations, usually hearing voices. They firmly hold false beliefs, delusions. They have abnormal thinking and behavior, reduced expression of emotions, diminished motivation, a decline in mental function, cognition, and problems in daily functioning, including work, social relationships, and self-care. Schizophrenia is proposed to be caused by hereditary and environmental factors. The treatment involves antipsychotic drugs, training programs and community support activities, psychotherapy, and family education. To diagnose schizophrenia with the DSM-5 definition, 2 criterion A symptoms are required. Additionally, a person needs to have at least one of 3 positive symptoms of schizophrenia, so either hallucinations, delusions, or disorganized speech. So let's have a closer look on these criterion A symptoms. At first, there is delusion. This is defined as false beliefs that usually involve a misinterpretation of perceptions or experiences. Next symptom is hallucinations. This involves hearing, seeing, tasting, or physically feeling things that no one else does. Auditory hallucinations are the most common. Then there is disorganized speech, which is characterized by a collection of speech abnormalities that can make a person's verbal communication difficult or impossible to comprehend. The 4th possible symptom is disorganized or catatonic behavior. This includes bizarre or inappropriate behavior, actions or gestures, and inappropriate or incongruous affect. It means exhibiting incorrect emotional responses for a given context. The last point on the criterion A list is negative symptoms. These can include blunted or flat affect, so emotional inexpressiveness and apparent unresponsiveness. Alogia, which means poverty of speech. Asociality, its apparent lack of desire for the company of others. Anhedonia, the apparent inability to show or feel pleasure. And avolition, that's the lack of will, spontaneity, and initiative. Lastly, let's have a short view on some other psychotic disorders. Brief psychotic disorder is at least one psychotic symptom for less than 1 month. Then there's schizophreniform disorder. Patients with this disorder display the symptoms of schizophrenia for 1 to 6 months, and it usually transitions to schizophrenia. So, patients may start with the SPD and then transition to schizophrenia. And lastly, there's also schizoaffective disorder, where patients have symptoms of schizophrenia and a major depressive, manic, or mixed episode. The major mood episode must be present for the majority of the illness. So this is a combination, actually, of 2 disorders of schizophrenia and then affective disorder.
Now, let's get into the second broad bin of psychological disorders that I would say is probably the most common, would be mood disorders. So these are disorders characterized by a persistent pattern of abnormal mood. And there's what we're referring to as affect and mood. So affect refers to an individual's visible emotion in the moment, and mood is sustained internal emotion that reflects his or her view of life. So when we look at things like depression, that would fall under mood disorder. This is a sort of a long-term impact on their view on life and the emotion they're going to portray. So somebody who's depressed isn't going to be smiling all the time and super happy and smelling the roses. Emotionally speaking, the visible emotion that you see would be a little bit more downtrodden, will be a little bit more on the negative side. And their internal mood would be that they feel like, what's the point of living? I'm so unhappy. I don't find happiness in the things that I should be finding happiness in.
The DSM-5 separates mood disorders into 2 categories. There are depressive and related disorders and bipolar and related disorders. Let's start by discussing the depressive disorders. First, there is major depressive disorder. This one is often called unipolar or major depression. For diagnosis, 5 or more of the following conditions must have been present nearly every day during the same 2-week period, and one of them must be depressed mood or loss of interest or pleasure. The conditions are depressed mood most of the day, markedly diminished interest or pleasure in all or almost all activities for most of the day, significant, so more than 5%, weight gain or loss or decreased or increased appetite, insomnia, often sleep maintenance insomnia or hypersomnia, psychomotor agitation or retardation observed by other, not self-reported, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate or indecisiveness, recurrent thoughts of death or suicide, a suicide attempt, or a specific plan for committing suicide. The next form is persistent depressive disorder. It is characterized by depressive symptoms that persist for 2 or more years without remission. PDD consolidates disorders formerly termed chronic major depressive disorder and dysthymic disorder. For diagnosis, patients must have had a depressed mood for most of the day for 2 or more years, plus 2 or more of the following conditions: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. Now let's talk about premenstrual dysphoric disorder. It involves mood and anxiety symptoms that are clearly related to the menstrual cycle, with onset during the premenstrual phase and a symptom-free interval after menstruation. The symptoms must be present during most menstrual cycles during the past year. For diagnosis, patients must have 5 or more symptoms during the week before menstruation. Symptoms must begin to remit within a few days after onset of menses and become minimal or absent in the week after menstruation. Symptoms are the following: marked mood swings, for example, suddenly feeling sad or tearful, marked irritability or anger or increased interpersonal conflicts, marked depressed mood, feelings of hopelessness or self-deprecating thoughts, marked anxiety, tension, or an on-edge feeling. In addition, 1 or more of the following must be present: decreased interest in usual activities, difficulty concentrating, low energy or fatigue, marked change in appetite, overeating or specific food cravings, hypersomnia or insomnia, feeling overwhelmed or out of control, physical symptoms such as breast tenderness or swelling, joint or muscle pain, a feeling of being bloated, and weight gain. Lastly, there is disruptive mood dysregulation disorder. This is a newly added classification to the DSM-5. DMDD is a mental disorder in children and adolescents characterized by a persistently irritable or angry mood and frequent temper outbursts that are disproportionate to the situation and significantly more severe than the typical reaction of same-aged peers. The symptoms of DMDD resemble those of attention deficit hyperactivity disorder, ADHD, oppositional defiant disorder, ODD, anxiety disorders, and childhood bipolar disorder. The next group you need to know about are the bipolar disorders. First, there is bipolar disorder type 1. It is distinguished by the presence or history of 1 or more manic episodes or mixed episodes with or without major depressive episodes. A depressive episode is not required for the diagnosis of bipolar I disorder, but depressive episodes are usually part of the course of the illness. The specifier with mixed features has been added to the DSM-5 that can be applied when patients have MDD or PDD. Next, there is bipolar disorder type 2. The DSM-5 diagnosis of bipolar II continues to require at least 1 episode of current or past hypomania and at least 1 episode of current or past major depression with no history of an episode of mania. Lastly, there is cyclothymic disorder. This one is distinguished by the presence or history of 1 or more manic episodes or mixed episodes with or without major depressive episodes. In addition, the DSM-5 criteria clarify that hypomanic or depressive symptoms must be present at least half of the time during the required 2-year period. Now let's talk about dissociative disorders. The first one in this group is dissociative identity disorder. There are conditions that involve disruptions or breakdowns of memory, awareness, identity, or perception. People with dissociative disorders use disassociation as a defense mechanism pathologically and involuntarily. Dissociative disorders are sometimes triggered by psychological trauma, but may be preceded only by stress, psychoactive substances, or no identifiable trigger at all. This disorder is formally known as multiple personality disorder. There are symptoms of disruption of identity that may be reported as well as observed. Next, there is depersonalization-derealization disorder. This disorder occurs when you persistently or repeatedly have the feeling that you're observing yourself from outside your body, or you have a sense that things around you aren't real, or both. Feelings of depersonalization and derealization can be very disturbing and may feel like you're living in a dream. The diagnosis of depersonalization-derealization disorder is clinical, based on criteria in the DSM-5. Patients have persistent or recurrent episodes of depersonalization, derealization, or both. Patients know that their unreal experiences are not real. They have an intact sense of reality. Symptoms cause significant distress or significantly impair social or occupational functioning. Now let's talk about dissociative amnesia. The information you lost in this type of amnesia would normally be part of conscious awareness and would be described as autobiographic memory. Although the forgotten information may be inaccessible to consciousness, it sometimes continues to influence behavior. For example, a woman who was attacked in an elevator refuses to ride in elevators, even though she cannot recall the attack. In a change from the DSM-4 to the DSM-5, dissociative fugue is now subsumed under dissociative amnesia. Lastly, let's talk about personality disorders. There are 10 types of them, which are grouped into 3 clusters, A, B, and C. In Cluster A, we find paranoid personality disorder. It is characterized by excessive distrust and suspicion. People with paranoid personalities rarely confide in others and tend to misinterpret harmless comments and behavior as malicious. PPD usually begins by early adulthood and is manifested by an overall sense of distrust and unjustified suspicion that causes persistent misinterpretation of others' intentions as being malicious. People with a paranoid personality disorder are usually unable to acknowledge their own negative feelings towards others, but do not generally lose touch with reality. The next type in Cluster A is schizoid personality disorder. People with schizoid personality disorder rarely feel there is anything wrong with them. Symptoms include an indifference to social relationships and a limited range of emotional expression. It manifests itself by early adulthood through social and emotional detachments that prevent people from having close relationships. People with it are able to function in everyday life, but will not develop meaningful relationships with others. They are typically solitary or loners and may be prone to excessive daydreaming as well as forming attachments to animals. The last disorder in this cluster is schizotypal personality disorder. It is a psychiatric condition marked by disturbed thoughts and behavior, unusual beliefs and fears, and difficulty with forming and maintaining relationships. Speech may include digressions, odd use of words, or display magical thinking, such as a belief in clairvoyance and bizarre fantasies. Patients usually experience distorted thinking, behave strangely, and avoid intimacy. They typically have few, if any, close friends, and feel nervous around strangers, although they may marry and maintain jobs. This disorder appears more frequently in males, surfaces by early adulthood, and can exacerbate anxiety and depression. Next, let's have a closer look on Cluster B disorders. There we find antisocial personality disorder. It is characterized by a pattern of disregard for and violation of the rights of others. The diagnosis of APD disorder is not given to individuals under the age of 18, but is given only if there is a history of some symptoms of conduct disorder before age 15. People with this illness may seem charming on the surface, but they are likely to be irritable and aggressive as well as irresponsible. They may have numerous somatic complaints and perhaps attempt suicide. Due to their manipulative tendencies, it is difficult to tell whether they are lying or telling the truth. Another disorder is the borderline personality disorder. Here you find an instability in impulse control or mood or image of self and others. So these individuals really don't quite grasp their personality and what they're expressing, and there's a change in that. So you see that they act very odd and that they are starting to express behaviors that you might not normally associate with them, saying, well, that's unlike them. Because of this, they have trouble actually defining their personality. This instability often disrupts family and work life, long-term planning, and an individual's sense of identity. Then we have the histrionic personality disorder. It is characterized by constant attention-seeking, emotional overreaction, and suggestibility. A person with this condition tends to over-dramatize situations, which may impair relationships and lead to depression. People with this disorder are uncomfortable or feel unappreciated when they are not the center of attention. Those with HPD take on the role of life of the party. Interests and conversation will be self-focused. They use physical appearance to draw attention to themselves. And the last disorder in Cluster B is narcissistic personality disorder. This is when individuals feel like they are better than everyone else, and more than maybe some of the proud peacocks you might know. They have no empathy, so if somebody's hurt or needs help, they're not there to help. They're those who say, well, you deserve that, or why should I help you? These are individuals who get something that's termed the God complex. And you see this sometimes with individuals who have highly impactful or important jobs. Things like doctors that are world-renowned neurosurgeons and are saving lives, but that doesn't necessarily mean that they're better than, say, the nurse who's assisting in the surgery. The last cluster is C, and here we find avoidant personality disorder. This is characterized by a lifelong pattern of extreme social inhibition, feelings of inadequacy, and sensitivity to rejection. People with APD may avoid work activities or decline job offers because of fears of criticism or disappointment from others. They may be preoccupied with their own shortcomings and form relationships with others only if they think they will not be rejected. Loss and rejection are so painful to these individuals that they will choose loneliness rather than risk trying to connect with others. The next type is dependent personality disorder. It is described as a pervasive and excessive need to be taken care of that leads to submissive and clinging behavior as well as fears of separation. This pattern begins at early adulthood and is present in a variety of contexts. The dependent and submissive behaviors are designed to elicit caregiving and arise from a self-perception of being unable to function adequately without the help of others. These individuals have great difficulty making everyday decisions, such as what shirt to wear or whether to carry an umbrella, without an excessive amount of advice and reassurance from others. The last personality disorder we discuss is the obsessive-compulsive personality disorder. Please be aware that it is distinct from obsessive-compulsive disorder. OCD is an anxiety disorder, and OCPD is a personality disorder, but nevertheless, some OCPD individuals do have OCD. People with obsessive-compulsive personality disorder have overarching concerns with things being perfect, so they are concerned with orderliness, perfectionism, and control over one's environment. They obsess about themselves and their room and their desk. Everything needs to be perfect, and to the point again where it supersedes and becomes the primary goal of their daily functioning.
So now what we're going to do is we're going to start going a little bit deeper into each specific state that I talked about. We'll start with schizophrenia. And so we know that schizophrenia has a very strong genetic link. And you can be genetically predisposed to this disorder. So the way we always figure this out is through twin studies. And we looked at both monozygotic and dizygotic twins. And in twin studies, we know that if one twin has it, it's a 50% chance that the other will have it or some type of form of schizophrenia. We know that genetics provides a biological predisposition and environmental stresses can elicit the onset. So in English, if it runs in your family, so if your father, your mother, or your grandfather or grandparents have it, it's passed on through genes, and you might be I like to say is pre-wired for it. It doesn't necessarily mean you're going to get it, but you're pre-wired or you have the predisposition to potentially get it. And if the appropriate environmental stressors or triggers are there, you can initiate the disease or the onset of the disease. So there's a lot of debates sort of in the community around what causes it. And I don't think anybody agrees on the exact cause, but we do agree that there's a strong genetic link. You would be predisposed, and there's things in the environment around you that might trigger or activate that expression of the disease. Now, there's a dopamine hypothesis of the disease, and when you see terms like this, what they're trying to do is understand and express the underlying mechanism behind why they think this disease is being expressed. This theory is still obviously up for debate, but it's been around for long enough where I would say there's some merit to it. And the dopamine hypothesis states that some of the positive symptoms that we're seeing are due to an overexpression, overabundance of dopamine. And you also can have hypersensitive receptors. So even if you have, say, the same amount of dopamine that you normally do, but the receptors that are going to bind to the dopamine are hypersensitive, you would still have an exaggerated response. And along with the hyperactivation of the temporal lobe. So collectively, these things are all revolve around dopamine. And this would explain some of the positive symptoms that we're seeing. Now, the negative symptoms are believed to be linked to the hypofunctioning of the frontal lobes. You also see something called brain atrophy, which is when the brain is actually smaller than a compared cohort. And we also have something called a decrease in convolution. So convolution is, if you look at an image of a brain and it has all the folds and all that kind of wormy-looking exterior structures of the cortex, that the level of complexity of folding or convolution is an expression of complexity or knowledge state. So how much information is actually there. So the less convoluted or smooth the brain is, the worse off it is. So you want your brain to be nice and convoluted and folded because that represents a higher degree of functioning. Now, moving on to depression, we're going to look at some of the biology behind that. And to do that, we're going to have to revisit this image I'm sure you've seen before in the biology sections or some of the other modules that we've already covered. And we're looking at what's happening at the synaptic cleft or synaptic junction between two neurons. And this is outlining the process of synaptic transmission. So typically, a electrochemical signal is initiating from a presynaptic neuron, so what we're seeing on the top, and it's going to pass a signal down to the receiving postsynaptic side. So a couple of points that we're going to highlight here. We have neurotransmitters, which are encased in synaptic vesicles, and these transmitters can include things like dopamine, GABA, glutamate. And when the appropriate signal comes, which would be an action potential coming down an axon, it would open voltage-gated calcium channels, and that influx of calcium would trigger these vesicles to fuse to the presynaptic side, release their contents, which would be, in this case, let's say it's dopamine, cause a release of dopamine, and that dopamine is going to travel across the synaptic cleft, which is the gap between the presynaptic neuron and the postsynaptic neuron, and that the transmitter will interact with a receptor, and we call those postsynaptic receptors because of its location. Once activated, that would open ion channels and allow the signal then to pass on, and the electrical signal gets converted down through the postsynaptic neuron. So this really quickly high overview of the process of synaptic transmission is what happens in a quote-unquote normal individual, or let's say a non-depressed individual. Now, in individuals with depression, we see that this process gets altered or gets skewed. So again, we're getting back to genetics. We know that this driver of depression is genetically linked. So if there's depression in your family, in your immediate family members, your mom, your dad, your brothers, your sisters, the likelihood that you would get it would be higher than a matched cohort of individuals who don't have it running in their family. So what's causing it? Where are we seeing it? Where we're seeing issues are in the transmitter levels in certain specific structures of the brain, including the frontal lobe, the cerebellum, the hippocampus, and a few others. So these are just sort of large ones that come up. But we'll know that there's an inappropriate level or amount of either transmitter or receptor or reuptake of the neurotransmitter, and that's leading to some of the issues that we're seeing leading to depression. So there is the monoamine hypothesis of the disease, and there's three kind of real monoamines that come up: dopamine, serotonin, and norepinephrine. And so inappropriate levels of any of these or a combination of these would lead to the expression of depression. And so a lot of the antidepressants that are out there that have been designed and formulated and identified work around the premise of modulating or reestablishing an appropriate level of either of these or all of these collectively. So dopamine, serotonin, and norepinephrine. So you should definitely know that for your MCAT, is you need to know the different transmitters that would be behind regulating and causing depression. Alzheimer's disease is a disease, I would say, that is most highly expressed in elderly folk. And it's the most prevalent form of dementia characterized by memory loss. So depression is a catch-all term that's used to represent a couple characteristic features. So, not to belittle the disease, but you might hear people saying, my grandparent is losing it, or my parents are losing it and they're forgetting things and they don't know where they are. I tell them something one day and they forget it the next day. So that those generalized characteristics would outline dementia. Alzheimer's is a little bit more specific, and it is the most prevalent, like we're saying, form of dementia. So anterograde amnesia is one of the key characteristics of that, and that's the inability to form new memories. So let's break down that term, anterograde amnesia. Amnesia, I think we all understand that means sort of memory loss and forgetting things. So anterograde means that you're forgetting things from this point forward, versus say something like retrograde amnesia, where you're forgetting things that you've already learned. So you're forgetting things that have happened since where we're looking right now. So we know that Alzheimer's is also a cortical disease affecting the outermost layer of the brain, the cortex. The cortex is what we were mentioning with the convolution and the folding. So it's actually impacting specific areas on that outer cortex, which is where we know a lot of that function happens. So in terms of the pathogenesis of the disease, or what's causing the disease, our understanding is actually still evolving. And, I was fortunate enough to actually do some research in the area. And back even 10, 15 years ago when this was happening, there was still the idea of what's actually causing the disease? So what we've at least collectively agreed upon is that there's an increase in the amount and level of something called beta amyloid. And beta amyloid is a very sticky substance, and it can stick upon itself, and it creates these things called beta amyloid plaques and neurofibrillary tangles, or NTs. And, for a long time, they weren't really quite sure what they do, but the working hypothesis is that the plaques, more specifically the tangles, create what we call synaptic clutter. So if you go back to the previous diagram that we had of the synaptic junction with the pre- and postsynaptic neuron and the synaptic cleft, and we had transmitter moving, the idea is these tangles can actually get in there and get into the cleft and block and get in the way and create garbage. So it prevents the presynaptic neuron to communicate with the postsynaptic neuron. So if you imagine one neuron trying to talk to the other, and you have something in the way, that signal is not going to be able to pass, and therefore you cannot communicate. Now let's imagine in this scenario that the information being passed is a memory. So memory is going from the pre to post, and you need to access that memory. If all of a sudden you have synaptic clutter or garbage or NTs in the way that are preventing that from happening, there goes transmission of that memory. So you now kind of lost a memory or are unable to form a memory. So that is the sort of the working model in a real brief abbreviated form of how we think Alzheimer's is actually initiated and is expressed. So abnormalities in the activity of acetylcholine in the hippocampus, is where the memory center of the brain, is also believed to be involved. So we have a combination of beta amyloid, and we have an issue, an abnormality in levels of acetylcholine in the hippocampus. Okay, so let's move on to Parkinson's disease, and this is a disease that's associated with some movement disorders. And what's happening here is we're seeing a disorder because of the death of a group of cells that typically generate the transmitter dopamine. And there's two specific areas that we're talking about. One is the basal ganglia. So you can see here the basal ganglia is fairly deep in the brain, so this isn't something you see on the surface. We also have something called the substantia nigra. Two very important structures that are generating the transmitter dopamine. And so deficiency in these areas of dopamine is what's causing Parkinson's disease. So we're going to work through sort of this figure here. On the left, we have a healthy patient, and on the right, we have a patient with Parkinson's. So in a healthy patient, you have the presynaptic neuron, and it would release dopamine. The dopamine would be captured by the cells on the postsynaptic side, and you would have your typical response. In a PD patient, you have less dopamine being released, and therefore you're not activating enough of the receptors, and you start to see some of the issues. And some of those symptoms that we're talking about are arresting tremor, which is when just sitting there doing nothing, you would see a hand shake. Slow movement, rigidity of movements, especially in the face. So if you're trying to go grab a pen, it seems like a lot of work to try and just go grab your pen, and it seems quite slow. And you also have this rigidity in the face. So what we're referring to here is normally, people are quite animated when they're talking, some more than others, but you see movements of the eyes, the face, the cheeks. Individuals with Parkinson's, they seem like there is no expression of movement in their face. So they speak slow, their face seems kind of rigid, and this is, again, characteristic of the fact that there's not enough dopamine. So an obvious solution would be, well, how can I somehow increase levels of dopamine? So the easy answer is giving something called L-DOPA, which is sort of a precursor form of dopamine. Biochemically, we're not going to get into all the specifics, but it gets broken down to release dopamine, and we see an increase in levels of dopamine. More recently, they've come up with agents that are dopamine agonists. You can even have things that cause a blockade of the reuptake of dopamine so that it ends up staying in the synaptic cleft a little bit longer. So everything is pretty much anchored on trying to increase the amount of dopamine that's available. So we're going to get into sort of a new late-breaking area, which is, we say new, but we're looking at about 10, 15 years of research. And that is looking at stem cells to regenerate neurons in the central nervous system. So the central nervous system is an area where you don't see a lot of regrowth of neurons, especially in areas like the spine. And so stem cells are undifferentiated cells that are, for lack of a better term, sort of blank slates. And they really haven't decided what they're going to be just yet. So they have the potential to be pretty much anything. So looking at this figure, we have the stem cells. They can go on to differentiate into becoming things like a neuron, an astrocyte, an oligodendrocyte. So they can do a lot of different things is the idea. So neural stem cells have the capacity to differentiate into anything. Yes, they can be put in the appropriate place and become what we call a progenitor cell and potentially migrate into the area of deficiency. So if we're looking at, say, Parkinson's disease, and we're seeing an issue with substantia nigra, the other areas where you don't have enough dopamine production, you could put in a stem cell. And the stem cell would become a progenitor cell and realize that it needs to become a cell that's producing dopamine. And so you could work in diseases where the deficiency is at the cellular level. So things like Alzheimer's, Parkinson's, and MS, where you need to reestablish the appropriate level of activity that's being modulated by the neuron, and you do that by looking at stem cells. So obviously, you have two base camps, those who believe that using stem cells is dangerous because of its potential to be used inappropriately. Some are against how they're harvested because typically you get stem cells from, or you can get stem cells from aborted fetuses. You can get them from excised tissue from young children. You could even get stem cells from yourself in appropriate key areas and reintroduce them to where you need them. But the whole process is barred with a lot of with adversity. But I would say those that are scientifically inclined agree And I'd say the general consensus these days is stem cells, especially if you can do something as impactful as addressing some of these disorders, is really, really useful.